Thank you very much, Ingrid, for your kind invitation to come and speak. And it really is a pleasure to come and talk to the families. We talk every day amongst ourselves, the clinicians, the professionals, but really why we're here and why we sort of get up every day, what we think about is how do we make and understand that child's epilepsy? How do we make them better? And we're always thinking of ways and new ways of actually approaching a problem, because really accepting that this is just epilepsy is not really the way we think anymore. And really, as Ingrid's very much sort of led the way in the world in this sort of understanding of epilepsy, and not just to understand it, but really now we're at the forefront of actually saying, how do we tackle these conditions? What do we do about them? How do we actually approach treatment and therapies? I'm approaching things just over the next few minutes, really talking about the principles of drug trials, because they can actually be very confusing. Lots of people say, oh, we need more trials, but really, what are they? What is the essence of them? And I'll also be talking about cannabis. It's a very important topic, and some other new data which is coming out, again, trying to answer this question about what will be the best for the individual child. Excuse me. I don't receive any funding for any of this at all. I don't have any sponsorship. Some money is coming to our department to help to support a trial where we've recruited 2 patients, but really I've no vested interest in this other than just making the children and finding out the truth. And I think this is what we all want to do and really find out, because that's the best way we can serve the children. But why do we need more treatments for epilepsy? Well, that's why we're here. We do need better treatments, because first-line treatments, disappointingly, when your child has epilepsy, you'll read, oh, look, it just gets controlled with a medicine, maybe 2 medicines, and that's it. But we're really dealing with children with more severe types of epilepsy. And Ingrid's given a very good illustration of really why they are severe, what sets them apart. And there is something different about this group of kids, so we can't really lump them all together as they'll respond to a medication. So we do need better treatment. Many will respond, but about a third don't. And the space we live in, about 10% of those kids with difficult control have got very difficult to control seizures. We're talking multiple daily seizures, injuries, falls, really not knowing where you're living one day to the next, really. The epilepsy is just this sort of relentless roller coaster, and we really want to put a brake on this. So there's many first-line medicines, second-line medicines, and novel therapies as well as other medicines you can discuss with your doctors, therapeutics such as ketogenic diet, vagus nerve stimulation, deep brain stimulation, even operative procedures as well. But really the purpose today is not talking too much about those, but just really more about drug treatment, which is a type of therapy. There are many different therapies as well. Excuse me. Many of the clinicians will be familiar with this, but really just tells you how drugs have gone and developed over time. This is almost like a chronology, sort of a roadmap of what's happened over time. And, we talk about the older drugs, bromide, phenobarbital, phenytoin, but you'll see here that more and more drugs came along. In the 60s, in the 80s, early 2000s, we came across lamotrigine, and then topiramate, oxcarbazepine, levetiracetam, and so on. So with each year, we're sort of getting more medicines, but really, is it making things any simpler? Probably not. It's giving us more choices, but actually that is a good thing, because we really see more and more therapies coming through. Now, we have to worry about, yes, are they good for our individual child? And that's a complex decision-making, but overall, drug therapies, choices are increasing. And it means that there's always new things to try, novel things to try. It doesn't mean we should try them without any rationale at all, but these are drugs that have been through the many phases, the clinical trials, and they've got to there because they've shown the safety, effectiveness in groups of people with epilepsy. And so the way we do this and select this is really just very much tailored to the child and family. And we want any intervention we're looking for to improve the seizures. Well, it's not just all about seizures, it's about the comorbidities, as we hear as well. So the ideal drug will help with learning, will help with socialization, interaction, alertness, all these things that hold the children back. We may then select really about the seizure types. In the classification, in our view, we see lots of different seizure types, and there may be certain drugs that work better for a type of seizure, and may have been a sort of an older traditional way, but that still holds when we don't have a precise diagnosis. Let's tackle the seizure, let's go for that. The syndrome is important because over our knowledge, our years, it's accumulated that certain types of drugs work better for each syndrome. It doesn't mean that every drug will work for that syndrome, but there are certain roadmaps we follow, certain tried combinations, and we've also seen how you can go wrong. You can go down the wrong path with historically something that wouldn't have worked in that condition, and only now we're finding out a bit more about it. And why it didn't work. But sometimes there isn't really any hard and fast rules, and even if people say, well, we shouldn't try this, well, if it's rational, if it's been tried, let's give it a go. And then there may be, disease-specific therapy. So we're drilling down onto the genes now. And as Ingrid said about sort of precision therapy, and I won't talk about it in more detail now. But of course, there are many dimensions to the epileptic encephalopathies. It's not just about epilepsy. And when we've got AEDs, which is the anti-epileptic drugs, having an impact in epilepsy, well, we're hoping that they're improving everything over here, the epileptic seizures. But by intervening there, they may certainly have a positive effect. We want them to have a positive effect, but also we find that sometimes they can actually have a negative effect as well. So in the example of Tegretol, carbamazepine, lamotrigine in Dravet syndrome, they may have a negative effect. And there's much in the literature about people describing, it's still important to describe the successes and the failures. And then about the cognition, the anti-epileptic medications, the drugs we're developing are often not tested in cognition. They're tested for seizures, so we're testing them for one thing. And so then we have to work out, are they having a good effect on the cognition? Are they having a beneficial effect? But quite frequently, are they having a negative effect? And certainly we've all seen how many medicines all together, combinations will actually make the child more tired, fatigue, and really it's not good. And then the actual, is there a positive effect in some of the medications? People say, well, actually, since we've started that, the child's a little bit brighter. Is this an observation we're seeing with some medications? And really, that's what we're after as well. And the physical disability, the comorbidity as well, can take a hit, but is there anything that improves that or worsens that function? And so on. The behavioural problems, there may be things that make it a little bit better, a little bit worse. Appetite, another important thing for your child. Well, yes, I can, but if it's going to make him go off his food, well, do I really want it? So there's so many different dimensions we're trying to juggle down, but really in clinical trials, often the endpoint really is just the seizures. And we don't have the drugs targeting specifically at the moment the comorbidities, but as drugs come into evolution and new trials come through, people are looking at these as other outcome measures as well, and it's important not to sort of forget that at all. Excuse me. So what are clinical trials? Now, clinical trials are really the cornerstone of what we have to do. And if a medicine comes out without a good clinical trial, be wary of it. It's people purporting it's good, which is good, and that's the start. But we really need good clinical studies to know whether this medicine is the right thing for our child. But it can be frustrating because then you say, well, where are the clinical trials? But unless we make a start and actually push for the clinical trials and actually identify the children that need the clinical trials, they won't happen. And really, it's as a cornerstone of actually good clinical practices, getting the clinical trials up and running. We don't get the trials up and running ourselves, but we can kind of come up with ideas. But we also, together as a community, will put pressure on people to think about this as a drug, think about this as a solution. So it just can start with an observation, and then it builds up into something. And they really test the treatments in human volunteers or patients to see whether they should be further investigated or approved for wider use. and the treatments having an acceptable safety profile for the disease or the condition, and the ones which are showing the most the most promise, and then move next along. So it's a process that we've got to make sure they're safe, we move along, and they really are the integral part of new discovery. And they are required by all regulatory agencies, the FDA, the TGA, will want evidence of its use, which is sort of commonsensical, really. We want to know whether these things work. And you'll hear this just briefly in this talk, but briefly there's many phases of the trials, and this comes from the NIH website on clinical trials. This is the US website, and if people are interested in that, and I think people after this should really be thinking about how do clinical trials work, because understanding of clinical trials makes them a bit less daunting. I think if you know what you're in for, what they are, what they answer, it sort of takes some of the mystery out of it. And I don't find clinical trials very well described at all, generally in the media. It's really just all or nothing, and that's the result. But there's lots of complexities to this. And there are many phases, and really essentially you go from phase 1, which are the dosing studies, to a phase 2 where you're looking at safety of the treatment. Only then you can go to phase 3. If we're not happy with phase 1, we don't progress. If we're not happy it's not safe, it may get canned at phase 2. It doesn't mean we can't do it again. We may revisit it a few years later, but really it doesn't go further. And then even after the medicines come onto the market, then we have to know whether it still is doing the job that it should do. There's still surveillance to make sure it's not doing any harm. So this is the phase 4. And what we're dealing with is sort of new treatments coming out in phase 2 and phase 3. And certainly the ones where they show promise in phase 3 may then be available through the regulatory agencies, but we don't stop there. We have to then understand more about those medications. But surely, why not bypass the trials as the drug works? It's worked in so-and-so, and that's really quite exciting when we see it working, and we really don't sort of ignore that at all. We have to really embrace that and find out why it does work, but it doesn't stop there. I think if then you extrapolate that, then it will work in everyone. We've seen how complex the epilepsy is. It doesn't mean we should be static and not do anything, but there are many different facets of not just the epilepsy, but seizures, and to lump it all together with it works, therefore we should start it is erroneous as well. So the problem also is that, you know, this is sort of a more in details of trials and why things may not work as well, and this is a problem with uncontrolled studies. So when they're not controlled, we don't have a nice control group, we're not comparing, and you're just giving it because you think it works. And there's so many confounders in that. You might be giving it to a different group of kids. You might be giving it to kids who are actually much worse rather than milder kids. You might be giving it to kids without even epilepsy at all. Or you might be giving it to people where they think it should work, and therefore it does work. And this is quite bizarre, but it happens in children, this placebo effect that if you think something should work, the expectation it should work does actually make things work, which seems bizarre if you're actually giving it on behalf of someone else, but it does. And also, I mean, this is actually one of the faults of drug trials, or one of the weaknesses rather, is that they may not actually reflect real life. I mean, they have to be done for a short period of time. You can't give a drug trial for a whole year, but they are done at a certain time. For example, you might reduce some of these errors by having a good lead-in time of 6 weeks whilst the child is actually on the baseline, and then the intervention comes, and then you'll actually measure the outcome, which is usually in seizures, measuring the seizures. There are other factors as well that we measure, but usually it's actual seizure outcome. So placebo is the inactive pill or liquid, and the placebo effect is a physical or emotional change occurring after an inactive substance is taken or administered, and the change may be beneficial, reflecting the expectations of the participant, and often the expectations of the person giving the substance. So the clinician may be affected by this as well. And in children's trials, a placebo response is actually higher than in adult trials. There's more likely 1 in 5 people, if you're giving them a trial for epilepsy and you're giving them placebo in epilepsy, they're likely to report a benefit compared to adults. But you know, one could explain that. Was the epilepsy just fluctuating? Did you happen to just give it at a time the seizures were getting better. We all know that it's not just a constant factor. If you give it a time the seizures were getting better, well, it was getting better whenever, whatever substance you gave, and that may have been placebo. And also, were the seizures accurately recorded? Were people just recording things not so accurately? Did everyone agree what was a seizure and what wasn't the seizure? Therefore, are people less likely to actually interpret a seizure when they're on what they thought was the right drug? And then, was the medication actually in the end superior to placebo in the end? And that's what we have to compare in the results, or was it just by chance? Did it really just look that, well, actually, the numbers that we gave placebo, numbers that we gave that should be balanced, should be the same group, but actually if there's not a big difference, it can just be a chance association. And that's looked for very carefully in trials and evidence. So moving on to the cannabis. Cannabis, many of us are familiar with this. It's the most widely, well, many of us are familiar with both really in the therapeutic space, most widely used recreational medicinal drug worldwide. Really, it's got a very ancient history in our culture. It's an old friend and maybe a foe. And it's best known for its psychoactive component, which is THC. Now, the thing with THC, though, that's can be proconvulsant. It can make seizures worse. And in adult epilepsy clinics, people may have patients who smoke marijuana, but their seizures are not controlled. It helps maybe people get through life, but maybe stopping sometimes the inhaled or smoking the marijuana may make your seizures better. But pure cannabis, the cannabidiol, is almost significant amount of THC. And really this is shown in vitro studies, so this is studies in the sort of test tube and then in animals, that it may improve seizures. It does improve seizures in models. And it was also known here because it's one of the major cannabinoids in Sativex, but the exposure to CBD in clinical trials is still quite limited. So if we look at some of the evidence of THC, it may be, as I said, maybe have some proconvulsant, as in it can make seizures a bit worse. And these are slides which Professor Helen Cross from London kindly lent me. Whereas CBD probably doesn't have a proconvulsant effect, but really looking at the actual discrete sort of studies and the conditions, it may have an anticonvulsant effect. And really, if you look at the actual CB1, so these are actually cannabinoid receptor agonists that are developed to actually work within the brain. They may have an anticonvulsant effect and less likely to be proconvulsant. So it's showing promise as a class of drugs, group of drugs that can have an anti-epileptic, anti-seizure effect. So this is where we are. So these are large preclinical evidence-based models, showing that it's showing a lot of promise. And hence the next stage. There was this study that many are familiar with, the parental survey, showing that in children on CBD, this was a social media invitation, showing that actually their seizures got better. And the CBD reduced seizure frequency in the majority of cases. And in that very sort of selected group, it had a very excellent side effect profile. But again, this is what the parents were reporting. We just have to be, this is what it is. And so we have to appreciate that, and that's what's recorded. But as we see, there can be some errors in if you extrapolate this to a bigger group. But these studies and this information is still a start. It's excellent that this is recorded and this is documented. Just for the interest of time, I probably won't go into this in too much detail, but really this study in 2016 showed that the medication, this was sort of an invitational study on people with and children with drug-resistant epilepsy. And this was to see whether it worked. And this wasn't controlled. There was no placebo. This was an open study. And this graph is quite challenging, but what you see here really essentially is when people started, each one of these bars is an individual person. You can just make out these bars, and the people where it came less than 0%, as in there was a reduction in seizures, are represented down here. Where there was an increase in seizures is over here. So you'll see that overall, if you like, the blue is below the line, there was an improvement in seizures. And if you look way down over the right there, that N of 5 means that there were 5 out of that 214 who were 100%. So there were some very, very good responders and seizure-free. But also there were some which were down here, N of 15, which were also the good responders as well. But really, can you infer too much in these groups here where they're not responding as well without really control? But where this was also leading to was also seeing about how it was tolerated. And on the whole, it may reduce seizure frequency, and there will be some very good responders. But the profile in children and young adults really is the safety profile, the side effect profile was actually fairly good. You know, if you look at other medicines that you have as well, we can get sleepiness, decreased appetite with many things as well. But it showed that, but at certain percentages, but not to the point that we shouldn't progress with this. And this showed the improvement with both Lennox-Gastaut and with Dravet syndrome. But there was a placebo control group here as well, and showed that there was an improvement in the total number of seizures, as well as the convulsive, the jerking seizures. Our compassionate access scheme, which is actually a way of administering a medicine such as cannabis, where there is no means of getting it, we've done in New South Wales. Our results, and this is John Lawson, my colleague's data, we actually gave it to a certain group who had multiple daily seizures. They were sort of, if you like, the worst of the worst. But what we found with that really also is that we couldn't really measure the seizure frequency. There were very few that were seizure-free, and there wasn't really a major change in the hospital admissions and the number of times to give rescue medications. So overall, we felt so far this is going to be submitted, but this didn't sort of stand the test of, well, this is making a whole lot of children, 30, 40, 50% seizure-free. And there's some other medicines on the horizon. Cannabis gel has been tried in normal intellect adults with epilepsy. That was well tolerated, but it didn't show any better than placebo. But the company are going back and saying, did we not quite use the right dosage? And this came out just recently. Again, this isn't been published in all the data, but the top line results in a cannabis gel in Fragile X syndrome with psychiatric problems, morbidities, showing that out of just 20 patients, they met the endpoint criteria with meaningful improvements in their mood. And lastly, I'm just talking about something actually very exciting, which is a fenfluramine. This is a drug that's been known for a number of years in photosensitive epilepsy, and it's been used in a lower dose. It did have its side effects with weight loss, and that's what it's actually used for. But the main side effect in the weight loss studies was actually cardiac, but in a group of people with severe photosensitive epilepsy, who many of them subsequently were found to have Dravet syndrome, it was shown to be effective. And the top-line results of that, published just in September, we haven't got the full data of that, showed that above placebo, 70% of patients had more than a 50% reduction in monthly convulsive seizures. And these are children with multiple seizures per month as part of Dravet syndrome. So that's actually encouraging, and the placebo response was actually quite low in this study. This was people from 2 to the age of 18. So randomized controlled trials are essential in children's epilepsy if we are to advance our knowledge of novel drugs. As more drugs are marketed for severe childhood epilepsy, the opportunity to enroll into drug trials will increase. CBD shows promise in Dravet syndrome and Lennox-Gastaut, but we do need more information and data. And early days, but fenfluramine through early results of a randomized control trial, a phase 3 study, appears to have a better efficacy in Dravet than CBD to date. Acknowledge everyone who's participating in the actual epilepsy program, as well as my colleagues at Sydney Children's and Professor Helen Cross in London, who's helped me with some of the slides and the cannabis.
I'm not sure if this one's working. Do you know how to? Thank you, Deepak. That was a wonderful overview about what we should be thinking about. If you've got a question, pop your hand up. I did want to make one point, which is because I stood up at just the wrong second, and you were just putting up the New England Journal of Medicine CBD study, and I think I rushed you over that. But I just wanted to emphasise this is the first study that's a placebo-controlled trial. There is nothing else in the literature. And Deepak referred to top-line results. They're press releases by companies, which tell us it's good. I'm sure they're true, but it's not been through the same process as when something is published, which is when you really believe it. And I think just to summarise the bottom line on this study, 43% of children with Dravet syndrome responded, and you heard for fenfluramine it's 70%. Responder is a 50% seizure reduction. So 43% isn't a patch on 70%, and 43% is the same as so many of the other drugs. So I just wanted to highlight that point. There was a question already, so we might take that from over there. Thanks, Olivia. Yes, please. Have you got the...
I had a question about the fenfluramine trial. Did it show anecdotally that other seizure types reduced as well, like the atypical absences and myoclonic jerks?
No, it's a good question. The caution with this, and I said, is always, we have to look at early data. So this is just really sort of almost like a press release. So I think really the proof will be, so when the groups have been finished and randomised, they sort of open the code, because you have to do that to make sure we're not making people worse or anything. So this is like an early release. It's not just designed to close to actually press release, because press releases come out when things don't work as well. You have to do that. But I don't know, this would be including the convulsive seizures. So within the convulsive, they included anything that was really jerking in the seizures. So I haven't drilled down, I don't know that yet.
There's a question, Deepak, over there.
Hi, I've got a question about fenfluramine also. I brought my daughter to see you about a year ago asking to go on the fenfluramine trial, but found out that it was a double-blind trial, so she may not get fenfluramine, and also that she had to get off stiripentol. And at that time, we were eligible to go on the CBD trial. Fenfluramine was my first choice, but as it was a blind trial, I decided to go CBD. Sure. We're still having a lot of seizures. I'm keen to go on fenfluramine, but do you know when it will be open label, so we know she'll be on 100% and she can still be on stiripentol? Yeah,
look, I think that's a very good question, but it's also one of the sort of the difficult things about trials. I mean, I talk to them as if they're all sort of easy to do, but they're hard. You're hard when you've got a child who's already having multiple seizures and their seizures are increasing, and you sort of can't break the code. You can't, but there is sometimes flexibility, but also if a child doesn't sort of last the trial, then that person is withdrawn for the trial. And always we want to do it for the right reasons, safety-wise as well. So if a child sort of epilepsy is getting worse, then you're safe is sort of almost like breaking the code and coming off the trial. So no, it is hard in younger children on the Dravet syndrome trial, I think, because sometimes I think with the Dravet in younger children, the epilepsy is still very much a state of flux. It can still be in older children, but whilst the epilepsy is shifting, it can be difficult. But, that's the way it is, and without that placebo, it would have not shown, or we don't know yet, it wouldn't show that level of sort of, rigour, really. But this then leads to other investigations, so then there will be other things in the pipeline saying, well, actually, if it's good for this, further investigations maybe with this and Lennox-Gastaut syndrome and other add-on trial designs as well. But I'm happy to discuss other things in the pipeline, but at the moment it's still the placebo control.
Yep. Question in the front row.
Hi, yes, asking about the CBD trials, of course. I'm wondering if you're ever going to look at trials that include more of the whole plant, because obviously my son has improved with what we access. The Pelican study also is showing that kids that have more of the whole plant are doing better than kids that just have CBD. So are we going to investigate that? Also, Hunter has recently his seizures increased, so we went back to coconut oil based, and they've decreased again. So are we going to be looking at those sort of variants, or are we just sticking with this and saying this is what we've got?
No, I don't think so. Again, I think I'd sort of just still see this as a start. You know, this is really just the first trial, as Ingrid said, that it's shown better than placebo. And then really after that, we have to see, well, are there any other tweaks, and are other people going to see that there's actually different types of the plant or different responses really will help. I don't think we may not have the whole number of children, say, with severe Dravet to do all the trials, but actually, again, with these trials have been international, multi-centre, and it's sort of set up a big network, really, of people. So I'm hoping that more children will be recruited. And if someone does say, well, actually, as drug development, we've found in phase 1 studies that it does seem to improve with different combinations of the cannabis plant, well, therefore, we can go to the next step. As inexorably slow it sounds, but the cannabis has actually moved very quickly. And I think, in a way, it's actually allowed everything else to move quickly as well, which I think is fantastic for trial development. I'm not an expert, though, on the actual sort of, I suppose, the excipients about the different, different compounds to actually improve absorption. But I don't know if anyone else has experienced that. People ask me about that, but I'm not sure. Yeah.
I'm just going to, there's a question at the back there, but there are two, we need quick answers, I'm afraid. So we have from Helen from Australia, CBD made my daughter's seizures worse during a trial. So would it be true that CBD, like all medications, can have a negative effect?
Simple answer, yes. Can make things worse, and that is one of the things that we have to be cautious with any new treatment. So we don't know why it makes in some children worse, but it can do.
And then Prem from Australia, would you recommend cannabidiol for a child on the milder end of Dravet syndrome to help improve cognition, sleep and hyperactivity?
Well, that's been an observation by many families that it may actually improve other aspects of Dravet rather than just the seizures. I think it needs to be explored. Until it's probably more consistently available on the PBS, I probably wouldn't at this stage. But I think we still need to find out more about it. And if it's not making the other seizures worse, then I think that probably will be another year or so.
And just to counter that, I don't know that it's going to be on the PBS, and that is a huge issue because it's a very expensive drug. The gentleman at the back's been waiting very kindly.
Hi, Dr. Gill. My daughter, I guess we've been privileged to be on the Epidiolex compassionate access scheme for the last 14 months. And had fantastic results. I guess had reduced from 32 hospital admissions over the 12-month period to 2 in the last 14 months. In saying that, she still does have seizures, they're just a lot shorter. The thing that concerns me, though, is that the scheme has changed for any new one coming in. So Dravet syndrome is no longer eligible to get compassionate access to Epidiolex. I see that as a backward move. And they now need to go through a blind trial to get access to this same product. Though Epidiolex isn't the perfect drug for my daughter, we did trial another product prior to Epidiolex, which we were off for quite a period due to certain reasons, and she had better results to that. There was more, I guess, whole plant molecules in that, but it is the only product we have access to at this stage. So I guess I'm just concerned for future families, and you say it's moved quickly, but it seems to be a backward step to myself.
Yeah, sure. No, I think that's a very good point, but as you say, it's sort of how do people still access this? And I think still we have to say, well, if the results are very promising for Dravet in the trial, we have to say, well, how can that change? How does that translate to more access for children? Because as Ingrid said, there may still be some hiccups and steps along the way where before Epidiolex actually gets the approval, and it's not a given that it will do. I think that's almost based on more evidence and more safety data and more trials. But certainly I think if patients have got severe Dravet and they've still got many seizures, and now there's evidence for that, then there may be other ways of compassionate access through hospital drug committees rather than just going on to the trial, if a person has got severe epilepsy and there's good evidence that it's actually worked. We wouldn't want to deprive them of anything that looks like promising.
I'm going to break my rule. There's a lady here who's bursting, but it has to be really quick. Oh, is it? Sorry. Yeah. It has to be quick. Everything has to be quick. I'm sorry.
Are we looking at changing the trials? We talk about our children as whole children, and given that cognition and behaviour and sleep are major issues, and we can look at those. I understand that some people say they're quite subjective criteria, but there are scales that can be used. You know, we should be looking at those things because they're what matter to us.
I agree completely. I'm very pleased to tell you that Professor Rima Nabout in Paris is designing trials with a much broader remit, and some of the families here have been helpful in looking at the other issues in Dravet syndrome to actually start to change trials, to not look just at seizure outcome but look much more broadly. It's got quite a way to go, but it's happening, so that's great. I think we better let Deepak answer further questions in morning tea. Would you please help me and join me in thanking him for a fabulous talk?